Hi guys, we're going to talk about patient safety advocacy and being a member of the healthcare team. And you'll find that on Unit 2 on the modules on page 15 to 17 in your packet. And so we're going to be looking at your Taylor book and also your drug dosage book for some theory on this. We're going to discuss the Texas Nursing Practice Act, Board of Nursing. We're going to look at the role that the nurse has in providing safe care and patient-centered care, and the role that we have when we're communicating with other members of the healthcare team in order to deliver that safe care. So when we're looking at the legal regulation, the professional and legal regulation of nursing practice, we are looking at position statement 15.27. That is the LVN scope of practice. You know, on the Board of Nursing website, you can find also the RN scope of practice if this is the direction that you are going to end up going into. But you want to understand what the LVN scope of practice means. You know, when you're providing nursing care and you're at the bedside, there are scopes of practice that you are held accountable for. And so the Texas Board of Nursing is there to protect and promote the welfare of the people. It's not there so much to protect and promote the welfare of the nurses. It's to hold your nurse accountable for the education, the licensure, continuing education credits that you're supposed to have once you have that license. And it's there to so that we as nurses, and when we are a profession, we're not just a career, we are a profession, that we are practicing competently and we are practicing safely for the good of the people. Your Nurse Practice Act, NPA, basically, there are laws in each state to regulate the nursing practice. And so your scope of practice there, for the LVN is this. The LVN is responsible for providing safe, compassionate, and focused nursing care to assigned patients with predictable healthcare needs. The reason why you need to understand that is that once we get into full assessments, when we're in 1323 and then 1402, your course, we're going to have you do head-to-toe assessments, and we're going to teach you how to do a comprehensive assessment. Now, the LVN is not responsible for that comprehensive assessment or maybe that first admission if you're in an acute care setting, but they are responsible to be able to understand what's going on and thereafter on a plan of care. But we are going to take care of predictable healthcare needs. The purpose of the statement that's there is to provide direction and recommendations for nurses and their employers regarding safe and legal scope of practice for LVNs, and to promote an understanding between the differences between the LVN and the RN and what we can and what we cannot do. The reason why that's important is because oftentimes once you start working, you may be placed in a position where you're going to be asked to do something out of your legal scope of practice. Now, if you do it, that is a decision that you have chosen to do, knowing that the LVN scope of practice will state da 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 da. And if the board comes down and asks, well, why did you do this? You can't use staffing issues or they made me do it type of thing in order to have an excuse as to why you carried out something out of your scope of practice. They will hold you accountable for what it is that you're supposed to know, regardless of whatever facility you're at. So you've got to be really careful, and you've got to understand what the board is expecting of us and how they do regulate and make rules and enforce and establish criteria so we can practice safely. So you want to work within your scope of practice. Or if not, you're going to answer to the board. They're the legal authority to allow you to, sit for NCLEX. They're the legal authority to figure out if you're going to go under disciplinary action or have a remediation, say for a medication error and things like that. So we do want to look at that and understand licensure. Your standards of practice are developed by professional nursing organizations to help carry out our roles. And so it's there to protect the patient, at some points, the nurse and the institution of healthcare. But really it is to protect the patients. We look at American Nurses Association, and so there are, guidelines that are there. Even if you go and specialize, say neonatal nursing, critical care nursing, mental health, and with these standards that are there, basically, what I'm trying to explain is that if, say, somebody went into early labor, it is under the standard of care created, say, by the critical care or OB nursing or what have you, that the woman be assessed within the first 30 minutes. Because what we are looking at when we're looking at this very big thing, the nursing process, we want to have positive patient outcomes. to include the baby in this case. If you have a patient that's walking into your ER and is having chest pain, it is through a standard of care, or a standard of practice, basically, that when that person walks in, the person will be assessed within such and such time, and they will have everything on board from oxygen to morphine, if indeed that person is going through a heart attack, that they be assessed and they be treated accordingly, so that there would be a positive patient outcome, based on symptoms that they are coming in with. This is the nursing process. So we're going to assess, we're going to see what's going on. We're going to diagnose. We're not going to diagnose the way a doctor does. A doctor will diagnose appendicitis. We are going to diagnose and take care of the patient based on their physiologic needs, based on their emotional needs in a holistic way. So we're going to diagnose pain because they're going to have pain, and we're going to treat pain. And so we're going to look at outcome identification. What do I want for my patient? How are we going to plan that out? Or what does the patient want for themselves? How are we going to plan that out so we can work together? How are we going to implement those steps? Are we going to treat pain with pain medication? And whether or not it worked for your patient, that's your evaluation. And so we've got to look at those things. We also have to look at documentation that's going to reflect these standards of care and these standards of practice. And we have to have care plans that reflect that for facilities, because otherwise, if we do not have documentation to support any of these things, then your health insurances or your Medicare, Medicaid, things like that, they will not reimburse facilities. They won't reimburse for the care that's supposed to be given. So we're looking at practice that needs to be documented, or our nursing care that's documented. We practice and we look at our standards or scopes, based on evidence provided by nursing research. That's evidence-based practice. Nursing is a blend of science and nursing. That's evidence-based practice, basically. What's the ultimate outcome is your patient's outcome. What is in the best interest for your patient. So the research helps you establish guidelines of care. So this is where we have our evidence-based practice. We look at clinical expertise. What's going to help? Based off of research and evidence, is this how we're practicing based off of our standards of care, and patient values and preferences? Is this going to benefit all together? And are we able to identify and have these guidelines for care for certain illnesses, treatments, procedures, surgical interventions, skills needed to initiate whatever level of care for the person? Protocols, alerts, procedural manuals. We're looking at all of this in order to establish that culture of safety. So your board of nursing, responsible for state exam requirements, licensing, unprofessional conduct, medication administration, and everything. So they do look at all that. They keep us responsible for what we do, even when we're doing drug administration, right? And so we need to ask, what's the patient condition? Does the health status warrant the medication, or are we just transcribing and administering? Does this make sense? Is this the correct dose? What's the setup for the math when we look at that, and is it correct? So we're looking at rights and medication administration, which you need to know, and know that and understand that when errors are made, they are subject to disciplinary action, legal implications, that kind of thing, through the board of nursing, because we've got to answer to somebody. And this is where the board will say, do we need remediation? What is it that we need to do in order to correct, what's going on? The board understands that we're not perfect, so they do look into certain cases, figure out what's going on, or all cases, figure out what's going on, and then issue the disciplinary action as needed. Incident reporting is mandatory documentation. Talks about the occurrence. Was there any harm to the person, anybody else around that person? Visitor, employee, that kind of thing. And so that is also what they go ahead and take a look at that. When the BON or even your facility is maybe looking into medication error, they're going to look for any trailing zeros, for decimal points, how we wrote out the possibly the transcription, or how we typed it into the system. Did we put U for units, or did we spell it out? Which generally, once you're entering something into an electronic health record, it should be basically spelled out so that it is fully understood what we're doing. They also want to take a look at make sure that we know what syringe we're using when we're drawing up medications. Are we using expired medications? What are we doing? Okay, your healthcare institution, of course, there's policy and procedures. We've got to follow that. We've got to follow our scope of practice. We need to make sure we are doing what we are supposed to be doing. So when we're administering insulin, we check with 2 nurses. We make sure that we're not using one pen for every single patient. If we're using an insulin pen, those are, patient specific. If it's blood products, an RN is somebody is actually licensed to go get the blood, assess the patient prior to administering. And then once it starts the infusion, looks good, patient's doing well, no reaction, we can hand that off to the LVN to monitor. Okay, there's assessments, administrative narcotics and wastage, and prevent, how we prevent falls. There's scales. There are all sorts of things that we can take a look at in order to provide safety and care in what we do. Okay, your patients have a right to ask, especially when it comes to medication administration. So just keep them informed. The more informed they are, the more that they will take a look at you and feel comfortable and confident in who it is that's taking care of them. Now, we don't have to know everything, but we can at least say, hey, you know what, let me find out for you. So they have a right to their information, whatever is going on, right to understand, a right for a choice, to be respected, to be able to participate in their own care, and obviously confidentiality and HIPAA and all that stuff. A right to appeal if they felt that something was not fair, to object and proceed with a complaint. And then they also have a right to access to care, and also to if you have a severe pain, injury, or sudden illness that makes you believe that your health is serious danger, you have a right to be screened. It's access to care all over you can have your patient that comes in into the ER, stays, has some sort of illness, has not had the flu shot. We do offer the flu, you should be asking, have you had your flu shot? Have you had your pneumococcal vaccine? Before you leave, in the best interest of the patient, would you be able to get this while you're here? As long as the health, the bill of health, warrants that, and you've got your doctor's orders and things like that. But your patient has rights as well to many things. Here you go, patient safety advocacy. So you've got the Joint Commission, okay, non-for-profit organization. It accredits and certifies your healthcare organizations. When Joint Commission is in the house, in your hospitals, basically, because they're walking down the units, they're taking a look to see if whether or not everybody is crossing their T's and dotting their I's, making sure that they're scanning their patients' wristbands and the barcodes and doing it appropriately and safely. They're making sure that you open medications at the bedside and not anywhere else. They're making sure you're offering appropriate education to your patients about procedures or not so much procedures, but about, care afterwards, pain management, your plan of care, okay? And so that's really, really important to take a look at, and we want to make sure that the organization and the nurses are meeting that performance, standard. And so then you're looking at your national patient safety goals, and those are really important. Those take a look at whether or not we are looking at that patient who is at risk for falls. We're looking at that patient who is at risk for bleeding because they are on blood thinners. We're making sure that we're reconciling medication lists. You can have your patient take this medication from home, another 5 medications from 5 different doctors, and then get transferred to a long-term care or a rehab unit. And we need to make sure all the medications are reconciled as to what are they taking, do they contraindicate, each other and that kind of thing, to make sure we continue good care. Medication administration, we'll look at that, and with the national patient safety goals and the healthcare culture of safety, they're going to look at the do not use list so that we don't make dispensing errors. So you guys can take a look at that. The notification of medical errors to the ISMP. I told you guys about that, the Institute of Safe Medication Practices. That's what, these are the guys that will take a look at these sentinel events and say, hey, we need to change the label to heparin. We need to take a look at how many errors are happening. How can we decrease the errors? How can we make medication administration safer? We have SBAR, and basically that's documentation, that's communication. We'll take a look at that. We have computerized documentation to eliminate errors, and the medical dispensing, you've got barcoding. There's a lot of things that we can do, but we're only as safe as the person putting in the orders and the person scanning the wristband, So there's your S bar. Basically, it's communication to allow for an opportunity for questions to be answered, to have clear orders if you're talking on the phone to somebody. So we want to assess the situation and the patient, the name of the unit, the background, what's going on, what's the cause for concern, and your assessment that matches that. So we've got to have information to provide to your provider. And then any recommendation that you think may work for your patient, or if your patient says, hey, this doesn't really help me for pain. I live with chronic pain. I would rather take this medication versus that medication. Offer that information up so that we can provide appropriate care. Being that patient safety advocate is extremely important, even if we're not at that bedside. You want to look at the assignment that you are given. Refusing to accept responsibility for which you are unprepared, or having adequate staffing. Those kinds of things that you will encounter, and things that you have to look at. Because once you accept that assignment and you are unprepared, then you are responsible for the patient there. Now, delegating nursing care, who can you give your, who can you ask to take your vital signs? Can you ask them to interpret the findings? Can you ask a CNA to go and interpret these findings? No, you can't. You're the nurse. You're the one that is expected to do that. You got unlicensed assistive personnel, possibly, taking urine to the lab and things like that. But it is your responsibility to find out what those results are. So there are certain things, based off institutional policies, procedures, scope of practice that you can and can't do. So you do want to take a look at that. So we've got an RN's level here, delegation. You got specialty cares, severe cases, sterile procedures, assessments, teaching, evaluation, and IV meds, basically narcotic pushes and things like that. Your LPN, take care of your chronic cases, because those are going to be your stable patients. Routine procedures should be pretty much, placed into this. And then your unlicensed assisted personnel will do routine procedures or activities of daily living. So you've got to be able to understand what you can and cannot delegate. When we're looking at delegation, you got the 5 rights to delegation. It's very important that you understand this too. So based on this decision tree is where you're going to say, no, I can't pass this down, or yes, I can pass this down. So you're looking at the right task. Basically, who can this be passed down to? What do my rules and regulations under my scope of practice support this? Does it support it? Does it not? Your circumstance. Does the facility allow me to do this? Does the state, the BON, allow me to do this? Is this even appropriate? The person, have I checked the patient's needs? Can I delegate this task based on the assessment? Can the UAP perform this activity? Can the CNA perform this activity? Are they capable? Do they know how? Do I have adequate supervision? Or what have you? And so you're going to have to be able to delegate the right person. Now, your direction and communication, that's important. Can I clearly describe what I need done? And can this be done to begin with? Okay. Supervision, is there somebody who can monitor, evaluate, is there intervention needed, and feedback? Can I complete this this in order to delegate? If there are any no's, and you stop right there, then you're going to have to take care of that yourself. And so there, as we move along into our 1323 course, you'll start learning a little bit more of what your responsibilities are and what you can and can't delegate. Okay, here we go. Use of evidence-based practices. Okay, this is just an example of how we use evidence-based practice for safety, patient safety. Once we get into NG2 medication administration and placement, you'll see that oftentimes if you already work out in the facilities, that you'll notice that if you're assessing NG2 placement, you'll hear or you'll take a look, and the nurse will place an air bolus into the NG tube to be able to hear that swishing sound and to say, quote unquote, we're in the stomach. But basically, this is actually not an evidence-based practice. And this is from a long time ago. And what they're finding is that, we can here, it shows you here that this tube, flows a straight course down the midline of the chest to a point below the diaphragm. The tube does not follow the path of the bronchus. The tube is not coiled anywhere else in the chest, and the tip of the tube is below the diaphragm. Okay. Basically, though, what you want to be able to see is a properly placed NG tube, and that's based off of X-ray, not air bolus. and I know you can't x-ray your patients every time you're checking for placement, but you will still see this air bolus to verify placement out on your in your units or in your long-term care facilities and what have you. But your number one standard of care based off of evidence is to always have a chest x-ray to make sure the placement is correct. Here we go, your safe environment. Okay, are you safe when you're preparing medications? Do you have working conditions that allow you to be able to do that? Are there distractions? How's the lighting? Is there a locked area for medication? If you have a med room, do you lock medication carts and computers, or do you leave your computers wide, open so that anybody can come in and take a look at patients' information? Your narcotic checks on every shift, got to make sure that's set up and that matches in the computerized dispensing, unit that you're using. Narcotic drugs that are not accounted for are reported immediately. Otherwise, it looks like whoever didn't return it took it. Identifying your patient correctly, that's complete safety there, so that we can give the right patient the right medication. For the patient, sensory deprivation or overload can affect how the med works, and I know we talked about that earlier too. Is your patient in severe pain and we didn't control that pain, and now when we give them pain medication, it's going to take them a while for it to work. Nutritional status, how's the protein levels? Is there a potency risk on what we're giving them? And also, when we're administering medications, we don't leave any medications unattended at the bedside. You also don't turn your back when you're offering medications, because you don't know what happens. You don't have eyes behind your head. So we're looking at that. We also want to know how we handle crush, dissolve. Are we using extended release? Are we using sustained release? Sublingual type of tablets or what have you. And so we want to be able to take a look at that and make sure we're safe with that. Let me see here. Here we go. Nurses work all over the place, network of professions as a member of healthcare team. We assist in planning, delivery, and coordination of care. You can refer to your book on collaboration. And then we also have case management, patient-centered care collaborative practice. There's different ways you can look at case management. There's phone triage or SSI assessments, which is kind of identifies your patient who may need extra care due to mental disabilities or physical disabilities, cognitive disabilities. And so we want, case management so that we can take a look at somebody who may not be able to manage their own, as well. And so the case manager will take care of medications, appointments, make sure a patient has a follow-up, so they don't fall into high-cost situations or conditions. It's all about cost containment and improve patient outcomes. We're looking at, where you're teaching to self-administer insulin to control diabetes. Well, you've got a diabetes educator. That person is there, to help manage that case as well. So that when the case manager takes a look at the whole case altogether, can we discharge this person on time? Is this person safe to discharge? Will a facility have any type of insurance reimbursement? Everybody's looking at that. Nurse advocates for the patient regarding medications and therapy. That's collaborative work. Do we work with our physical therapist if the person needs to get up and move around? Do we work with occupational therapy? Are we communicating with these people? Like if you have your physical therapist coming by and you haven't gone to get administer medication, well, the person may not want to get up because they're in pain. So are we able to kind of keep on top of these things for the better, the better of the patient's outcome? So we're looking at that, being a member of the healthcare team. Your medication assignments for an LVN, the NPA indicates a scope of practice regarding medication administration, what the LVN can and can't do. So it just depends also on facilities and what the scope of practice is as well. But IV push medications like narcotics basically are not allowed in the acute care setting. There's moderate sedation medication used to manage in an unstable patient. Care and management of central lines. Those lines go all the way directly to the right atrium of the heart. And if we manipulate those in such a way, we can cause an arrhythmia. Peripherally inserted central catheters, those are not allowed under the Nurse Practice Act. So you've got to take a look at your scope of practice. If you're being asked to do these things at a facility that you're working at, and we're not saying that you can't or you don't understand that, We've got wonderful LVNs that do a whole lot, that have a great amount of experience, and that are more seasoned than your brand new RN that's out there. But are you crossing that line with scope of practice? So be real careful. And your role basically is an advocate for the patient. You collaborate with people around you and your healthcare team. You communicate. That's big in healthcare. In order to improve care. Your aims of nursing. This is something you'll always hear about here on out. And this is really what nursing is about. It's to promote health, prevent illness, restore health, and facilitate coping with disability or death. And so that's pretty much what nursing is, and you'll hear that here on out, and how we do these things once we move forward into our theory, once we get past drug dosage, okay?